Warm welcome, Dr. Raetzke.
Good afternoon. Like you said, my name is Brad Raetzke. I'm an emergency physician. I work at Riverside, Grant, and Dublin Methodist Hospitals. What I'm asked to speak to you about is drugs on the street. I know nobody here has ever seen a case of an overdose, suicidal attempt, or too much use of alcohol. We never see that Friday night, Saturday night. It's never intentional. What I want to do is I want to speak on drugs that maybe we're not so familiar with. And I know we've all seen a lot of alcohol, cocaine, heroin, and I'll touch on those because those are important and we need to know about those. But what I want to talk with you about is some up-and-coming drugs that we haven't seen, that we may be starting to see, because you guys are our frontline response. You need to know about it. You need to kind of keep that in the back of your mind so that we can initiate the appropriate therapy. I have no disclosures. And so the way I want to approach this is first, obviously, tell you who I am. As I mentioned, I'm an emergency physician. I did train as an emergency technician back about 10 years ago, so I do have some understanding of the field, and so I can appreciate what you guys see on the scene, the chaos, the difficult nature of that, and so I think that can make me better as an emergency physician. I want to talk a little bit about how to approach poisonings, what to do, what information to gather, what's your initial approach on the scene. Especially, I want to really focus on making sure that everybody understands, what happens in the field and then what we do in the emergency department, because I think that transition of care can really expedite the care for everybody. I'm going to talk a little bit about some of the common street drugs: heroin, cocaine, meth, bath salts. I know that's the latest rage right now. And then some of the newer drugs that maybe people haven't heard of so much: hand sanitizer abuse, K2 and spice, Khat, and some other ones that will be a little bit of a surprise. So as far as the initial approach, this is what you guys do day in and day out. This is what I do. It's your ABCs. It's your initial approach. So at first, don't even worry about the drug. Worry about their airway, breathing, circulation. Take care of that. Most of what we do in toxicology and treatment is supportive care. Some of the more fancy things we get down the line after we've stabilized their airways, assessed for any additional things. So obviously, mental status, ethanol, heroin, are they breathing? Are they obtunded? Sometimes, they're a little bit drowsy. Maybe we can talk about an antidote. Maybe we can try Narcan. But maybe they're just completely out of it, and maybe it's not even worth trying that and just get a definitive airway. As far as heart rate, so bradycardia, tachycardia, very common side effects with the drugs. Most of the time we can deal with heart rates in the 50s. We can deal with heart rates up in the 140s. But you start to get outside of those ranges, that becomes very life-threatening, and we need to identify those. So that's very important to put them on, get a life pack, get a 12-lead EKG to look at some of those dysrhythmias that we can. And through some of these toxidromes I'll talk about, that'll tell you what to anticipate so that we're kind of ahead of the game instead of behind the game. Other things that are associated with these overdoses. So is there a trauma? Did somebody become obtunded enough and hit their head, fall down a story? Does their altered mental status have nothing to do with the drugs? They're at a bar, they're drinking, had a couple beers, they're found down in the bathroom. What happened? Are they so intoxicated that we need to go ahead and provide an airway? Or did they actually get assaulted? And, having worked almost every 4th of July and New Year's Eve for the last several years, this is a very big problem in our emergency department. We see these people, couple drinks, or very intoxicated, fell off the bar stool, slipped at the bar. I can't assume that that's alcohol. So we need to treat these almost like trauma patients at times. If there's any small history, I don't care, they fell off a chair, they stumbled, we treat them close to a trauma patient. Two New Year's Eves ago, I had a 26-year-old male who was intoxicated, smelled of it, slurred his speech. We put him back in one of the rooms, finally got a story, well, maybe he fell off the bar stool. I didn't see anything on his exam, but pretty much my rule of thumb is you fall in alcohol, you get a head CAT scan. Well, 15 minutes later, there's a subdural bleed and the patient's in the OR within 45 minutes. Now, on New Year's Eve, when we're seeing 40 drunk patients in the emergency department, that can make a big deal if you just put them in a room, say we'll sober them up and send them home in the morning. So make sure you think about trauma, make sure you think about glucose levels. Depending on what age of kids that are into alcohol, you can drop glucose levels, either intentional or non-intentional. Temperature. Everybody who comes in with an overdose and an altered mental status, temperature, whether they feel warm or not, this is a common thing that we see and something that can be life-threatening. So full set of vitals, temperature and everything. So the initial approach is to stabilize. After that, let's get some history on the scene. Let's talk to people there. Let's look around. Are there drug bottles there? You know, even if they have a drug bottle of something that doesn't even seem important, I want you to bring it with them. Because at the very least, that'll tell me what pharmacy they go to. And we'll call the pharmacy and get a full list of drugs. So it's important to gather any information from you, from the scene that you can. Is there any funny smells, open containers? Is there anybody there that can provide any history? And then once we can identify the drug, hopefully, we can start talking about some of the antidotes that we use. So a little bit farther down the line, this is what I kind of deal with mostly in the emergency department is some of these antidotes here. But you guys, everybody uses Narcan, okay? Altered mental status, possible overdose, let's give Narcan. Tylenol, we have an antidote for that, N-acetylcysteine. So we need to initiate that early on to prevent death of the liver. Benzodiazepines, flumazenil. This is always a tricky one, and I'd just like to take a little sidebar to talk about flumazenil. This reverses benzodiazepines. It works great. If I happen to give too much benzodiazepine to a patient in the emergency department, I can give a little flumazenil, wake them up. I don't have to intubate them. Watch them for a couple hours, send them home. The problem is, if somebody is a long-time benzodiazepine user or uses multiple drugs and we don't have a good history, we can, and we think it's maybe benzodiazepines, given flumazenil actually may hurt them, because I'm going to take away any effect that benzo has, but what if they've done other drugs that cause them to have a seizure, a TCA? What do we treat seizures with? Benzodiazepines. What do I give to block? Flumazenil. Therefore, I have nothing to treat the seizures with. So make sure you use this very, very judiciously. The only time a lot of us emergency physicians will ever give it is if I know that I gave too high of a dose and I can avoid intubating the patient. Other than that, I will not use it. Beta and calcium blockers. We can give glucagon, insulin, ethylene glycol. So that's what you kind of see in some of your antifreeze. My favorite one, you can start them on an ethanol drip. Give them some shots of alcohol, and that's how you treat it. So there's also a commercially available drug, flumazenil. It's very expensive. If I ever have one of these cases, I'm going to do an ethanol drip just because I say I can. That's why I give cocaine topically for the nose if there's a nosebleed, because I can. All right, so at least through my training as an emergency medical technician, they really didn't cover on toxidromes, syndromes. So syndrome is a collection of symptoms that we see. We try to place them into it. I know everybody's heard of anti-cholinergic drugs, sympathetic drugs, but I kind of like to redefine and explain to you some of the most common toxidromes, syndromes that we see. And this helps you kind of identify the patients, and whether what drug they took, you can all treat them as the same. So maybe you don't need to know exactly, are they on amphetamine or cocaine? Doesn't really matter. We can actually treat them very similar and get them the appropriate care. So there's 5 common syndromes: sympathomimetic, speeding up everything; anti-cholinergic; cholinergic. Everybody's favorite and the most common is opiate, sedative, and ethanol syndrome; and serotonin syndrome, which I think goes underdiagnosed a lot of the time. We don't think about it. It's a little bit more subtle sometimes, but it's definitely common, and we've seen it several times in the last couple of weeks. So I'd like to touch on that. So sympathomimetic. This is our typical cocaine, amphetamine. People do decongestants that have dextromethorphan in it. So what does it do? It speeds everything up. This is your fight or flight syndrome. So I basically just think of, if you get scared, if you're in a stressful situation, this is what you're going to have. We're just making it artificial. You get high blood pressure. Not uncommon to see 190s, 200s, 210s. They're agitated. You're going to see tachycardia. Again, heart rates in the 150s, 180s. You're going to see dilated pupils. That's used as one of our evolutionary techniques so that we can see better in dark. So I just kind of think of this as your fight or flight. This is a synthetic, you're in a fight type of situation. Your pupils dilate. And then delirium. When you get to the end of the spectrum, they get very delirious. In overdoses, high doses of cocaine, amphetamines, we get cardiovascular problems. So this is when need an EKG. If they're severely out of it, I'd put on the pacer pads. This is the dysrhythmias that are concerning and we need to act on quickly. This is when you can make a difference. Give fluids. They're going to be, most of the time, hyperthermic. And then there's this condition called excited delirium, which is the very end of the spectrum, where they're hyperthermic. They're 105, 106, 107 degree temperatures. They are extremely out of it. They have high potassiums. This is the crucial part where we need to take very good care, get the IV in, lots of fluids, cool them. This is, wet them down, throw water on, turn on the fans. We need to cool them down, and then we need to give benzos to sedate them. And a lot of times in the emergency department, we'll actually go ahead, intubate them, paralyze them to remove all muscle tone to allow them to cool off. These are very difficult patients at times. This excited delirium will take 5 or 6 police officers to hold this patient down to allow you to administer the medicine. So if you have to, these are the patients that if they're so out of it, you may have to intubate and paralyze to allow the appropriate treatment. These, unfortunately, don't have any antidotes. The antidote is time. So we're going to have to just wait it out, treat them, treat the problems. Like I said, fluids, benzos, try to get them in a calm environment. The next one, Anti-Cholinergic Syndrome. So you've probably heard of anticholinergic drugs. The most common drugs that we see that have this side effect, Benadryl, antipsychotics, so Haldol, Geodon, antidepressants. So a lot of our antidepressants that it seems like almost everybody is on today, if you take that in an overdose, as Prozac would, you're going to get what's called an anticholinergic syndrome. So, and probably the most common one you'd see in teens, other than Benadryl, is something called Jimson Weed, and we'll touch on that a little bit later, and I'll touch on a little bit more of the symptoms. But people are very delirious. They're out of it. They're not making sense, but they're not really sedated too much either. They mumble. You can't understand them. They're tachycardic. They got the dilated pupils, warm. They got warm body temperatures, and they have seizures a lot of time. So again, flumazenil likely not good in this case. I think of this as anticholinergic is dry. So if you see a lot of these symptoms, tachycardia, dilated pupils, that sounds just like the last one, the sympathomimetics. These patients are dry. So if you're in a fight and you're revved up, your epinephrine's going, you're going to be sweaty and you're going to be jazzed and you're going to have a hard time holding them down. This is almost the opposite side where they're delirious, they're tachycardic, but they're bone dry. This almost looks like heat stroke is kind of how I picture it. So we do have one antidote for this. This is in the emergency department. It's rarely given. Again, it's usually supportive care. We do give this for severe dysrhythmias when their QRS widens, if they're starting to have seizures. This medication here is called physostigmine. The problem with this is if they've taken a tricyclic antidepressant, a TCA, with this, given this drug will cause their heart to stop. You go right into asystole. So we use this as a last resort for people who we cannot control any other time when they're developing dysrhythmias due to a known anticholinergic. So a Benadryl overdose, Jimson Weed overdose. All right, so our third syndrome. So we talked about the sympathetic, where you're revving up, but you're still sweaty. The anticholinergic, where you're a little bit delirious, but you're still revved up, but you're bone dry. This is the opposite of those. This is where you're what I'd classify as wet. So this is when you vomit, you're urinating over yourself, you're having diarrhea over yourself. It's the type of patient that they're diaphoretic. You don't even want to touch because all your EKG pads are going to fall off. It's kind of a mess. Luckily, it's relatively uncommon. The typical times we see this is organophosphates, insect killers, fertilizers. So it's usually not necessarily intentional, but somebody who's working out in the fields who's just exposed to it. The typical case, at least, they describe as somebody who's working in California, but definitely can be in Ohio, who's out in the field. When they're out in the field and it's moist in the morning, all of the insect killers actually go off of the plants and get onto their genes, get absorbed into their system, and then they become delirious. They're peeing. It's just a big mess. So they use the acronym SLUDGE. So salivation, lacrimation, urination, diarrhea, GI upset, and emesis. Nerve gas overdoses present as this way as well. So the antidote for this is atropine, and you give high doses of atropine. It's routinely that we have to bring up multiple doses from the pharmacy because we've run out in the emergency department. So you basically give atropine 1 milligram every 3 to 5 minutes until they start improving, until they dry out, until things improve. So you can easily have 8, 10 doses. Again, I don't think this is the definitive care that they need to be all better by the time they get to the emergency department. But if they're bradycardic, if they're severely symptomatic, a dose or two may definitely help and improve the outcome. And this is everybody's favorite here. So opiate, sedatives, and ethanol. Narcotics, benzos, barbiturates, clonidine, all these in overdoses cause you to be sedated. It decreases your respiratory drive. We've seen this, respiratory rates of 6, 8. Very constricted pupils for most, but not all, drugs that they can take. Narcan. So, and it's all based on your EMS protocol likely. I usually start with a 0.4 milligram dose, a lot smaller than a lot of times what I see coming in. I think this is a good dose if the patient is kind of mumbling and out of it. You notice that their respiratory rate is decreasing. But if they're completely out of it, I think you need to jump to the higher doses. So I see a lot of 1 milligram, 2 milligram starting doses, and that'll tell you right away. That's kind of their altered mental status coma cocktail. Just on a side note here, one of my favorite drug inserts is Narcan. It tells you that you can give 0.4 milligrams to 2 milligrams, and you can repeat as necessary. But if you get up to 10 milligrams of Narcan, it says you may want to consider an alternative diagnosis. So I don't know if anybody's ever pushed Narcan, but 10 milligrams, yeah, I think you better consider something else, trauma perhaps. And then serotonin syndrome. So this syndrome is caused by either an overdose of medications that block serotonin in the body, or it's caused by the addition and polypharmacy of medications. So a lot of the antidepressants, they're called serotonin reuptake inhibitors. What that does is it stops the serotonin from being broken down so that you have more of it around. It gives you a better feeling. Well, if you add multiple of those drugs, or if you add some drugs that have that side effect, so if somebody's on Prozac and they were seen in the emergency department or at their family doctor and they were given Ultram, that drug combination can cause them to go into serotonin syndrome. The drug can actually have been stopped, like the Prozac could have been stopped up to 2 weeks ago, and you'd still have the side effects if you're given tramadol. So I think with all these multiple visits to emergency departments, your urgent cares, I think you're going to see a lot more of this. So just keep this in mind. I think it's very difficult to determine. The couple cases that I've had, it's been difficult and we're not quite sure, but they seem to fit it. And so it's one of those we treat because that's the worst case scenario. So here's kind of a little graph of what you can see. So you get diaphoresis, they're agitated, you're holding this patient down, they're tachycardic, 170s, 180s. I give multiple liters of fluid, no change. When you check their reflexes, they're hyperreflexic, so they just jump off the table. And you just notice that they're very unstable. Their blood pressure is 210, 220. They're very, very sick appearing. That's the one end of the spectrum. The other end is they're starting to see some of these side effects, and they're a little bit of this, a little bit of that, and that's when it's very difficult to determine. So obviously stop the drugs. That's the one. And then there's an antidote called cyproheptadine. The one kicker with this is, it makes my life difficult sometimes, is these patients usually aren't quite with it. This drug is only given orally. So my choice is I either keep them not intubated and convince them to chew this pill, or I have to intubate somebody who has no respiratory problems, but I got to put an NG tube down to give it. And so unfortunately, most of my cases have been that way, is that we've just had to force it down them. never pleasant for either person. So kind of just wrapping up some of the common street drugs that we see. Ethanol, it's in the sedative category. Cocaine, it's sympathomimetic, so we get revved up. Heroin, sedative. Cannabis, sedative. LSD, it's classified as both a hallucinogen, but it gives you the sympathomimetic properties. They're usually pretty revved up. And ecstasy is sympathomimetic. So I kind of put this in the common street drug category now because I think we've all heard about it. I think, raise your hand if you've seen a case of this. Okay, so a large majority. So, you know, you're all smart people. I don't want to bore your time with this, but I do want to touch on it for some people who haven't seen it, and just kind of let you know the state of affairs that we are seeing now. Basically what it is, it's a chemical called mephedrone, or MPDV. There's a couple different categories, and they can kind of tweak it a little bit to help avoid detection. What it does is that they put it in this container, they label it bath salts. On the back of the container it says not for human consumption. Well, I don't think anybody really uses it to take a bath and smell better and smell like mephedrone. This is kind of what we're seeing a lot of the new drugs to be is they're synthetic, they are designed to avoid detection, and technically because they're not a certain compound, they are actually legal. So this is legal because, or was legal, because it's new. There's other drugs I'll talk about that are technically legal because you have to identify the exact chemical in order for them to be on a scheduled controlled substance. It's similar to cocaine and amphetamine. You can't detect it most of the times. In fall 2011, they put an emergency ban on this. Since that time, we've been seeing a decrease in cases, but I talked with the Poison Center, and they're still seeing about 1 to 2 cases a week. They were seeing about 20 cases a month at the height of this. Just from personal experience, we were seeing a lot of that. It's kind of dropped off. These people are very sick, and it's very difficult to control them. So the average dose is 5 milligrams to 20 milligrams. Each packet contains about 500 milligrams. So you really hope that people are a little bit educated when they're taking this. Otherwise, they're going to take the whole thing and overdose, and this is what we see, and that is why it's so dangerous, in my opinion, is that people don't know what they're taking and how much they should take. So as you see right there, not for human consumption. Why did they start taking it? Well, it actually stimulates a little bit, and it can improve your attention in lower doses. It's not the lower doses that we're concerned about that we get called out to see. It's these high doses when they take the entire package. There has been some case reports with this of people given Haldol for sedation causing cardiac dysrhythmias and death. So it's very difficult from us to sedate these people with the appropriate medications. So I wanted to talk on some new drugs of abuse. Some people have heard of, some maybe not. But this is things that I think we're starting to see a little bit, and I think it's important to be familiar with. So we'll start off with K2 and K3. So K2, again, another synthetic. This is synthetic weed, essentially. They market it as incense. This sounds very familiar to bath salts, if you remember. It's more expensive than weed, but the advantage is that it's not detected in most drug screens. What they do is they manufacture the synthetic weed, they put it on different particles, and you can inject it, smoke it. Essentially, it's similar to weed. You get a little bit more tachycardia, psychosis, and slurred speech. People have a harder time. It's more potent than the THC and most marijuana, so we start to see a higher doses, a higher effects than what you'd expect to see. The next one, this plant is called Khat, and it's been around for generations. It was first documented use, I think, in 600 AD. It's used in a lot of cultures. It's a stimulant. They chew it throughout the day. It's mainly the weeds and the leaves, and it has to be fresh. So it's basically a sympathomimetic drug, all right? So it's going to speed everything up. It increases your heart rate, your blood pressure, it causes psychosis and diaphoresis. Again, this is a drug that we're starting to see a little bit more. They've actually got some really sophisticated, I guess, cartels who will transport this as it's fresh. They harvest it in the morning, they'll fly it over here or to Europe to be used the same day because you need it to be fresh. So as you see, I mean, it's technically legal. I just kind of mentioned that. The one interesting thing in this is they've done studies and they found that heart attacks happen in these countries that use it 1 to 2 hours after what they call the chewing times early in the morning. So they see about 9 or 10 o'clock a huge increase in myocardial infarctions because of some sympathomimetic effects. We see it in young people, 25, 26. They're seeing a lot of heart attacks as a result of this. So both Khat and cocaine are associated with heart problems, so make sure, if they're saying chest pain, treat it as real chest pain. Obviously in cocaine, avoid the beta blockers, but make sure you take those complaints serious in addition to the overdose. This is one of the newer drugs here, Krokodil. Raise your hand if you've heard of this. Okay, so maybe about a third of you. Nickname, the drug that eats junkies. So this started in Russia. Basically, they've found it in Germany within the last year or so. There's been some case reports here in the United States. Basically, it's made from codeine, which in Russia is legal to buy over the counter. They mix it with gasoline, paint thinner, hydrochloric acid, which sounds like a wonderful drug to take. It takes about an hour to make. It's similar to morphine. So the chemical name is desomorphine, but it's about 10 times as potent. It's easy to make, it's cheap. So I believe they can get about a third cost reduction to make this as opposed to using heroin. The way that you ingest it is you inject it into your skin. This is where the problem occurs. It breaks down your skin. So what you do is you'll see some green scaly marks on the skin. It starts to break down the arteries and veins. It stops the blood supply. It basically then just necroses your skin, and it goes to the bone. So I want to show some pictures, but I'll just warn you, they are pretty graphic. This is real life, but this is what we're seeing in Russia right now. So you do see the skin breakdown here. You see all this surrounding necrosis as well, and he's got it here. They actually say in Russia that once you start on it, your life expectancy is for 1 more year. Once you start on this drug, most people die within a year. It's that potent, it's that dangerous, and it's that life-threatening. Again, this is a common user. She's peeling off all the dead skin. I can't imagine people doing this to themselves to get a high, but like I said, their life expectancy is 1 year after starting it. It goes down to the bone. All right, let's go to something complete opposite, hand sanitizer. It'll clean it all up. We're seeing this here in the United States. California has seen quite a bit. 2010, they saw 2,600 cases. This is cheap. It's everywhere. We're using it in the hospital. You're using it in your rigs. It's $1 to buy anywhere. So what is in it? There's an alcohol there that's more potent than ethanol. They're seeing that younger kids are trying this, so it's easier to go than go to Manny's liquor store in the corner. Oh, well, mom's got a whole bottle of hand sanitizer. Let's just drink this. Well, some people drink it straight up, and that's got to taste really bad. Other people will distill it and can add salt to it, and tips are on YouTube. Don't look at it, guys. But you're able to distill it, and it actually tastes a little bit better, apparently. So what is in it? So ethyl alcohol, it's similar to ethanol, but it's more potent. What you can actually see is that this is a 62% concentration. If you put it into proof terms, it's over 120 proof liquor. So 2 or 3 shots for the kids, that's just 4 or 5 milliliters, and you're seeing very significant effects. The other problem is some actually contain isopropyl alcohol, which people don't tolerate quite so much. This is basically rubbing alcohol. And so you get nausea, flushing, they decrease their CNS, and you can see the fruity odor. So that's one of your tip-offs for that. and we have to actually hemodialyze them if they get the wrong kind, the isopropyl. Visine ingestions. Has anybody seen a Visine ingestion? Yeah, they're not too common. I've had one case of this, and this is usually more for a suicidal attempt, or it's an attempt to be funny and play a practical joke on somebody. So the urban myth is that putting a couple drops of Visine will cause diarrhea. It actually doesn't do that at all. That's just a myth. As little as 1 to 2 milliliters of this can cause profound hypotension, can cause cardiac disturbances, and people end up in the intensive care unit with just 1 to 2 milliliters of Visine put in a drink or an ingestion. So basically, we just have to support it, put them on pressors, lots of fluid, and monitoring. So this is something called 2CE. Again, it's a synthetic drug. It's a psychedelic, so it's similar to LSD, PCP. We even know who invented it. It's actually unscheduled, so technically it's legal here in the United States because the FDA hasn't looked at exactly what chemical or gone through the processes to put it on a scheduled controlled substance. It's crystal powder. It's a little bit more expensive, but the latest prices on the internet that I'm seeing are $50 for 100 milligrams, and that'll get you about 5 to 6 trips. You either orally take it, just put it on your tongue, or you can snort it. You get nausea, vomiting, diarrhea, itching, muscle spasms, hallucinations, and the sounds are distorted. Again, hallucinogen. There's not really a whole lot of antidotes for it. It's just some sympathetic care, just treat the symptoms. Jimson Weed, it's common in teenagers, it's kind of the most common we see it. This is where you're going to see the anti-cholinergic. So basically, this is like atropine, and actually in parts of it, there is atropine, there's hyoscyamine and scopolamine. Scopolamine is used for the patches for travel sickness. All these are anti-cholinergic medications. Long history of being used and abused. It goes back to some Shakespeare's plays. It grows almost everywhere, and so we see either teens abusing it because they can get some high effects from it, or farmers can get it unintentionally by just being around it and having it rub off. So people will eat the seeds, they will smoke some of the leaves, or they can make tea out of it. So it's actually classified as a belladonna medication, which is a little bit interesting because back in the times in Italy, females used to take a couple drops of this, put it in their eyes, it dilates their pupils, and they thought that was more attractive to the males. The anticholinergic, so this is when we were talking about the dry syndrome. So you're blind because your pupils are dilated, you can't focus very well, you get hot, you get dry, so these are the anticholinergic effects that we see. You can give charcoal if it's early on. The latest stance is that we give charcoal if it's within an hour of ingestion, if the patient has able to take things by mouth and not a huge risk of aspiration. A lot of times we're kind of using the poison setter to help us decide whether to give charcoal or not, because it's not quite as effective as we thought, but it does work well for this. All right, so kind of just summing up here. Obviously, when you initially get on the scene, it's initial stabilization as if it was any other patient. Try to identify the drugs, get a full set of vitals. Hyperthermia is huge and is a problem in these ingestions. If you can, put them in one of those 5 boxes, and that'll kind of let you to know what to expect, because you may be seeing the early effects of this ingestion, and you want to kind of prepare and be ready for it. So we talked about bath salts. Again, the temperature, blood pressure, benzo's not Haldol for this. Synthetic weed, you get slurred speech. It's, again, supportive care. Krokodil, it's going to be very damaging to the bone and skin. It's limited here in the United States at this point, but this could be an up-and-coming thing. Hand sanitizer. The caution is kids, especially when they're young, can't deal with alcohol very well in the sense that their blood sugar will drop. So if you see or suspect one of this, you need a blood glucose right away, because kids do not deal well with alcohol. All right, Visine we talked about. Make sure, poison center is there. They're very good, so make sure you can always get online control with them. And I want to give thanks to Dr. Hayes, who assisted me and kind of let me know what the Poison Center is seeing and dealing with. They're seeing a little bit less bath salts, but continues. The 2CE, they're starting to see a little bit more of, so that stimulant. All right. Does anybody have any questions? In the back? Could you speak up? Sorry, could somebody relay that? I couldn't. Oh, bath salts? They're dilated. Yep, so you're going to get the sympathetic, so they're going to be sweaty, they're going to be hallucinating, tachycardia, high blood pressure, and dilated eyes. Yep. All right. Well, thank you very much for your time. I know you've had a long day.